Okay, well, in the interest of time, Gerry, do you want to give us your signpostings as to how we can
Love to, Matt. Yes, thank you. I'll try sharing my screen. So, is that working? You're on mute now, Matt, but yes, that's fine. Right. So you've had quite a lot of talks about health economics and what we can do. This is going to be a lot. It's going to be a lot more light. I think this is not that there's going to be any gags in it, but it will be a lot lighter than the previous presentations. I'm going to talk a little bit about how you might access health economics advice and support, but more generally about all support for applications proposals going forward. Okay, so I'm particularly going to talk about the RDS, which is the Research Design Service. There are 10 RDSs across the country, and unfortunately they don't fit in, they don't align completely with the ARCs, of which there are 15. The ones at the top, the northern ones, do tend to align, but the ones further south don't. The purpose of the RDS is to offer a fit-for-purpose advice and support on research design and methodology to researchers making funding applications. The idea originally was to support applications to the research for benefit, patient benefit funding stream of NIHR, to increase the number and proportion of those. There was a feeling that the applications going into that funding stream in particular weren't particularly great quality, and they wanted to improve that. I think that's happened, and I think that also the remit of RDS has been expanded. So we now support not just RFPB, but all NIHR and indeed some charitable applications. There's an idea that there should be a consistent national coverage for these programs. So what's the value of the RDS? Well, I think one of the top one is probably the most important. It's a critical friend to help you consider all the issues that might arise with your proposal at an early stage. We might also discuss the best method to answer your research question, whether that be, for example, a trial or some sort of analysis like Chris Boyke was talking about earlier. Meet and build relationships with experts in the field. So it may be that you don't have a health economist or a statistician, but that the RDS can point you in the direction of someone who can help you out. I think one of the most crucial things is that most RDS people sit on or observe funding panels, and they sort of get a feeling for the zeitgeist, if you like. So what's going on? What makes those panels tick? What makes them fund particular things and not fund particular other things? What sort of makeup of a team they're looking for, and so on. So I think that is really crucially important, and it does give you a real advantage to know what your funding panel or funding stream is looking for. Also, unfortunately, most of them are very well aware of the application process and the onerous nature of it, so they will have been through that process, and then they'll probably know who you need to talk to if and when you hit a problem. We also assess readiness to submit. So quite frequently we will get people coming to us with I'm going to submit this in 2 weeks. What do you think? And quite often the advice coming back would be, I don't really think it's ready to submit in 2 weeks. Why wouldn't you wait for another till the next call comes out in 3 or 4 months? And also with the application reviews, you get a structured feedback. So whenever we receive an application, we will go through it with a fine-tooth comb and provide a detailed email about how you might address particular issues. So adding value, we talk about things like questions that are relevant to clinicians and patients. So try and avoid low priority ones and sort of not big up necessarily, but state the importance of the problem. Ensure that appropriate design and methods are used. So it says here that 50% of studies are designed without reference to a systematic review. It's not shocking, but it's a negative when it comes to funding panels. So if people are aware that there is a systematic review out there and that hasn't been referenced or included, then that's seen as a negative. We'd like to see accessible full publications. So we really just want to ensure that studies do get published. A lot of studies don't. A lot of them just fall by the wayside because they have a null result, or they are deemed it is not feasible, and that's not seen as a particularly interesting result. But that's biased, I think. And we want to see ultimately a usable report. So ultimately, this boils down to a reducing research waste. So we want to have better and more research, and we want to reduce the amount of research waste. So the RDS helps with all sorts of things. Literature reviews, we can help you out with how to do one. We can look at funding streams and give advice, and we quite frequently do give advice on the appropriate funding stream. So it may well be that within NIHR there are several potential funding streams available, and sometimes we can't answer the question of which is the most appropriate. It may be that there are several, and it then becomes a case of, we advise you to talk to the program manager or the respective people at the relative funding stream, relevant funding stream, who can talk you through that. But we do talk about appropriate funding streams. We do talk about study design, as I said before, whether it's RCT or qualitative research or whatever. We can talk you through that. Feasibility, we do quite a lot of feasibility work, I think, particularly because a lot of the work we do is still around RFPB and is still around the entry level, if you like, research. So we get a lot of people who haven't got a particularly strong NIHR track record. And a lot of the time, the easiest way in, or a common way in, is to look at a feasibility study for RFPB, which has some funding and gets you on the sort of the trajectory to being an NIHR researcher. The involvement of patients and public is absolutely key. I mean, I can't emphasize that enough. And I think as health economists, historically, that's something that we perhaps haven't paid that much attention to, but now is absolutely, it's pretty much mandatory for NIHR applications. And it's not just involving the patients and public, it's making sure that involvement is meaningful and appropriate, and that it's not just tokenistic. So you do see, or historically have seen, examples where PPI is included, but it really is just a case of putting Joe Blogs on who's a patient and in the public, who'll talk to us. But it doesn't really, it's tokenistic and not really very meaningful. Of course, the research team we can talk about, and obviously that does include health economists. So some of the time we can signpost you to health economists, statisticians, and whatever. That I think there is. There are health economists on each of the RDS in each of the RDS areas, but I'm not absolutely certain about that. But they should all be aware of health economists and other people that you would need to help you in your research team. Ethical considerations, obviously, I have very little to do with that. I'm aware of them, and I will point people to the relevant people in York or elsewhere. And we can also talk a little bit about impact. We have our impact research champion is actually based at York, Alison Booth, so she's happy to talk about issues of impact. So what the RDS does not do, what we don't do, thankfully for me, but probably unfortunately for you, is write the application protocols. We do get people coming to us and saying, we say, you need a health economist, you need a statistician, you need someone to do the systematic review. And the clinician, for example, may say, who do I get to write that? And that's where it's sort of, there's a bit of a gap there, because we don't do that and the clinician doesn't have time to do that. So that is an ongoing issue, but that's something that the RDS don't do. We don't help with projects where there's no intention of submitting, and we don't support applications that are not research, such as audit. Sometimes I appreciate that the line between research and audit is maybe slightly blurred, but there has to be ultimately a research question that we can address. We don't provide supervision or informal support for students, and we don't continue to support applications where the work has remained unchanged from previous submitted versions. But having said that, if it's tweaked to be more suitable for a different funding stream, we will of course consider that. Working with the RDS, I say book an early appointment with the RDS with a summary, one side of A4. the way that it will work is that we'll put face-to-face meeting there. Actually, these are older slides, and these are probably pre-COVID. Now, obviously, it may well be a Zoom meeting, and I don't know what it's going to look like in a year or 2 years' time. But what I mean by that is a one-to-one meeting where you'll first meet with a generalist who has a general knowledge of the research environment, but then we'll follow up with specialist people, health economists, statisticians, and so on, who will review your application and say whether it's strong enough or it needs more work in that area. I'm going to skip that because there's an awful lot going on in there. Initial meeting with the RDS, we will talk about the importance of the question, potential funding streams, again, study design, clinical area, the feasibility of the recruitment strategy. So one thing that panels do pick up on a lot is when people say that they're going to recruit X number of people, panels do pick up on whether that is actually feasible, and if it's not, that's a big negative. Track record of the team, and clearly that varies according to the funding stream that you're going for. PPI, as I've said, is pretty much mandatory and has to be in there. We'll also talk about costs, research, support, treatment, and excess treatment costs. I'm going to leave it there because it's 1 o'clock. That's my contact details if you've got any queries on anything RDS related. There's also, this is the RDS for Yorkshire and Humber, which does have some useful resources that you might want to tap into that you can find there. But I will leave it there because it's gone 1 o'clock.
No, that's fabulous, Gerry. Thank you very much. And you started a bit late, so you were on time. Don't worry about that. I'm going to hand back to Andy now, but I will just conclude by saying I really enjoyed it. I think it was a great idea to put this together, and I think the speakers have all done fabulous jobs. So I think well done to Andy and well done to everyone. But Andy, it's your last word, so I'll leave it to you.
Yeah, thanks, Matt. Well, I'll just echo what you've just said, actually. And I think David actually captured it in his comment that you put in. I think he wrote, "It's rare one sees the length and breadth of a field in one session, from definitions to cutting edge research." And I think that captures it perfectly, actually. And that's down to the speakers and your expert chairing, Matt. But I mean, the speakers particularly, and the way that they coordinated their talks between each other just made it sort of run seamlessly. So big thanks to everyone. And then also the people that have made it work behind the scenes. So the people at the Yorkshire and Humber ARC, James, Shahima, Amy, Katie, just want to say a special thanks to them as well for making things run so smoothly. So we'll be, as I said, we've recorded it. We'll be making the recording available, and the slides I think we can put together and distribute as well. So finally, thanks to everybody for joining us today. Really, really interesting discussions, and thanks for being so engaged. Thanks, everybody. We'll see you soon.